Brown's phase model, improving chronic disease management through exercise and behavior modification.
A very special thank you to Dr. Jessica Brown for being an incredible mentor during this whole entire process. Our knowledge about research and our successes we have shared as a team this past academic year could not have been possible without her support and guidance.
Chronic disease is becoming the new normal in the United States. Currently, 51.8% of the population has one or more chronic disease, with 25.5% of adults having at least two. This shifting dynamic means that this special population is now representing the majority. With many adults falling into the category of having chronic disease, it is critical to have an effective way of exercise prescription for this population. Cardiovascular disease, not including hypertension, is prevalent in 9.9% of Americans, with hypertension itself being 48.1%. Type 2 diabetes is estimated to be undiagnosed in 10.5% of the population, with 46.4% of American adults having prediabetes. 13.7% of Americans are diagnosed with asthma or COPD. Importantly, these conditions often overlap, with patients frequently presenting with more than one diagnosis.
Cardiovascular disease, often referred to as heart disease, are disorders associated with circulatory system and heart, and includes four main types: coronary artery disease, cerebrovascular disease, peripheral artery disease, and aortic atherosclerosis. Type 2 diabetes mellitus develops when the body's response to insulin diminishes, leading to insulin resistance. The body starts by compensating by producing more insulin to maintain blood sugar levels, but over time, the insulin production decreases. This progression is driven by the pancreas's inability to secrete enough insulin and reduce effectiveness of insulin-sensitive tissues in responding to insulin. COPD is marked by progressive airflow limitation and lung tissue damage. This disease arises from long-term exposure to harmful particles or gases, particularly cigarette smoke, and is marked by progressive airflow limitation and destruction of tissue. Obesity, a chronic and progressive disease, develops from excessive weight gain due to an imbalance between calories consumed and energy expenditure. Obesity can be influenced by cultural, societal, and genetic factors, and is closely linked to decreased physical activity, endocrine disorders, and insomnia, all leading to an increase in mortality and morbidity.
While each disease has its own pathophysiology, they all share a common impact of diminished quality of life and reduced physiological functioning, particularly in strength and cardiorespiratory fitness. Physical inactivity is both a consequence and a driver of chronic disease. It contributes to obesity, which in turn increases the risk for type 2 diabetes, cardiovascular disease, and COPD. This creates a cycle of inactivity, disease progression, and functional decline. Current exercise prescription guidelines remain separated based on each condition. For those with more than one chronic condition, recommendations are to revert to general guidelines or whichever the most conservative protocol is. This system limits the amount of personalization that can occur with exercise prescription. The abundance of fit principles can become impractical, specifically in a population where most individuals are not presenting with just one chronic disease. This approach creates a significant gap in the effectiveness of exercise interventions for the growing population of comorbid disease. Brown's phase model was developed to address these limitations. It offers a unified phase framework that accounts for the overlap in functional limitations among chronic disease populations. Though integrating individual medical history, assessment results, and personal goals, this model allows for safe, progressive, and tailored exercise prescription.
Our purpose statement. The purpose of our study was to evaluate the effectiveness of a phased 12-week individualized exercise and behavior change program prescribed using Brown's phase model for individuals with chronic diseases.
Data collection took place at Carroll University's Rehabilitative Exercise, or CURE Clinic, located in Waukesha, Wisconsin. Participants diagnosed with one or more chronic diseases completed a 12-week individualized exercise and behavior modification program based on the Brown's phase model. Our study specifically involved CURE clients diagnosed with cardiovascular disease, type 2 diabetes, obesity, and/or respiratory conditions. We chose these 4 chronic conditions because of their higher prevalence levels. Pre- and post-assessments measuring key physiological variables such as systolic blood pressure, diastolic blood pressure, cardiorespiratory fitness via determining the peak oxygen uptake or VO2 peak, upper body strength to weight ratio, lower body strength to weight ratio, and quality of life were completed. Assessments were conducted to measure participants' body composition via waist to hip ratio, balance and fall risk via the unipedal stance test and the Tinetti balance assessment tool, peak oxygen uptake via the Shackelford protocol, modified Bruce protocol or 6-minute walk test, muscular strength via estimated 1 repetition maximum during testing of the lat pull down, shoulder or overhead press, chest press, seated row, leg extension, leg curl, and leg press. Muscular endurance via the core plank test and the chair squat test, and flexibility via the modified or chair sit and reach and the shoulder back scratch test. We conducted paired sample t-tests to determine significant statistical differences with a p-value less than 0.05, proving effectiveness of the model.
The sessions in Brown's phase model is composed of 30 minutes of cardiovascular exercise, 50 minutes of strength training, and 10 minutes of balance and stretching. Each exercise session is individually tailored by the exercise physiologist based off each participant's medical history, assessment results, and their motivation.
Figure 2 breaks down Brown's standard of care phase model. Participants are referred to Carroll University's Rehabilitative Exercise Program, otherwise known as CURE, via physicians from local hospitals or family members or friends of current CURE participants or students. A thorough medical screening and any received physician notes assists the exercise physiologist's understanding of all aspects of each participant's medical history. Completion of assessments is then the final step for the exercise physiologist as an individualized exercise prescription is ready to be created for the participant. Table 1 explains the 4 different phases that each participant falls within. Phase 1 looks at low intensity of about 30 to 45% of heart rate reserve and one estimated 1 repetition max is for cancer survivors who are currently undergoing chemotherapy and or radiation therapy. The goal of reducing side effects of treatment is within this phase. This phase occurs during treatment or within 1 month following cessation of treatment. Phase 2's moderate intensity of 40 to 60% heart rate reserve and estimated 1 repetition max is for patients who are diagnosed with any combination of chronic disease or cancer survivors who are either completing phase 1, entering the program following treatment, or patients who are not undergoing chemotherapy or radiation. The goal of phase 2 is to correct any functional and physical deviations that result from immobility, disuse, or cancer treatments. Improving physiological function and beginning lifestyle education, as well as establishing SMART goals, are imperative during phase 2 of Brown's phase program. This program lasts for about 12 weeks and can be repeated if patients are not ready for phase 3. Phase 3's moderate to high intensity of 60 to 85% heart rate reserve An estimated 1 repetition max is for patients who have completed phase 2, with the main goals being improving physiological and psychological function via progressive overload to reach the apparently healthy status. Primary focuses on education, building self-efficacy, and intrinsic motivation for maintenance of the lifestyle interventions are communicated between participant and exercise physiologists during these 12 weeks. This is the end of the formal rehabilitation model. Phase 4 is a push for maintenance in the participant's life, where moderate to high intensity of 65 to 95% of heart rate reserve and estimated 1 repetition max can be upkept indefinitely. For those who have completed phase 3, the main goals are to adopt a formal physical activity routine and maintaining improvements in physiological and psychological function for life.
Table 2 represents patient demographics. 121 patients composed of 79 females and 42 males completed the Brown's phase model. The average age for the population was 66.41 years of age, with a standard deviation of 11.19 years of age. Average height of 65.95 inches, with a standard deviation of 4.59 inches, and an average weight of 196.23 pounds, with a standard deviation of 53.98 pounds. Figure 3 represents disease stratification. Around 54% of the participants had cardiovascular disease, 15% had type 2 diabetes, 6% had obesity, 4% had pulmonary disease, and 21% had other chronic conditions, orthopedic limitations, or cancer. Figure 4 represents the percent change in systolic blood pressure, diastolic blood pressure, VO2 peak over the course of the 12-week exercise prescription. Systolic blood pressure had an average decrease of 2.42%, and diastolic blood pressure had an average decrease of 3.44%. These reductions in blood pressure express a clinically meaningful reduction in cardiovascular disease risk. VO2 peak had an average increase of 6.33%. This is significant because an increase of your VO2 peak by at least 1 milliliter per kilogram per minute equates to a 10% reduction in all-cause mortality. Figure 5 represents the percent change in chest strength-to-weight ratio, leg strength-to-weight ratio, and quality of life over the course of the 12-week exercise prescription. Chest strength-to-weight ratio increased by 20.63%, and leg strength-to-weight ratio increased by 29.8%. With an older clientele, this is important because with an increase in their strength, it makes ADLs easier to complete. Quality of life increased by 4.37%. The increase in muscular strength reduces cardiovascular disease, type 2 diabetes, and improves quality of life.
The objective of our study was to evaluate the effectiveness of a phased 12-week individualized exercise and behavior change program prescribed using Brown's phase model for individuals with chronic disease. This model offers a unique framework for exercise prescription, integrating the 3 foundational pillars of exercise prescription. Medical history, assessment results, and client goals and motivation allowed for tailored exercise sessions for everyone while still adhering to the principles of exercise training, ensuring progressive overload is a priority. A unique feature of this model is the inclusion of structured behavior modification. Unlike traditional programs where behavior change discussions may only occur monthly, Brown's phase model incorporates regular clinician-led conversations focused on 2 SMART goals per phase. This consistent emphasis on behavior change equips participants with the tools and accountability needed to sustain long-term exercise adherence, which is critical for long-term change. Our findings demonstrated significant improvements in VO2 peak, systolic blood pressure, diastolic blood pressure, upper and lower body strength-to-weight ratio, and quality of life. This means Brown's phase program led to improvements in cardiovascular health, functional capacity, and quality of life, which are areas that typically decline across all chronic diseases. VO2 peak, a well-established predictor of cardiovascular mortality, reflects cardiorespiratory fitness. Increases in VO2 peak suggest improved aerobic capacity, providing the participants with the ability to perform daily activities with greater ease and reduced fatigue. Reductions in systolic blood pressure and diastolic blood pressure reduce the overall burden on the cardiovascular system, decreasing the risk for cardiac events. The improvements in both upper and lower body strength-to-weight ratio suggest better musculoskeletal function, resulting in decreased fall risk, as well as the ability to perform ADLs, which can often increase independence. Lastly, gains in quality of life suggest that this model supports improvements in overall well-being as well as physical health.
Take-home message of our study is that Brown's phase model serves as an example of a standard care model for chronic disease. It is applicable across multiple clinical populations, adding precision to exercise prescription in those with any combination of chronic diseases, therefore eliminating the need for multiple fit guidelines.